Hi everyone. I think there's about 350 people in the audience. I don't think I've ever spoken to quite so many people. I'm quite glad I can't see you all, otherwise I think I'd be more nervous. I also realised that looking at the diversity on the panel, I think as an underrepresented group, as a privileged white middle-class male, I'm pretty sure that's why they invited me. But it's lovely to chat to you all. So I'm going to chat to you about supracondylar fractures for a little bit, hopefully fairly quickly. So there's a supracondylar fracture. A little bit about how you assess them. So there's always a bit of confusion about Bowman's angle. So draw a line down the shaft. Remember, Bowman's angle is not, it's not this angle, it's actually this angle. So it's very, very difficult. So some of the literature talked about this, about the Bowman's angle, but originally the Bowman's angle, this angle. If you don't believe me, that's the screen grab from Bowman's paper. So it's a line perpendicular to the long axis of the shaft, and then a line at the physis of the capitellum. It's this angle, and this angle should be 70. This angle should be about 20, or compared to the other side. And the other thing we look at is the anterior humeral line, and we want to see that kind of intersecting the capitellum. And it is a bit age dependent. The younger you are, the further forward you'll be. But that's kind of what we want to see. Okay, so I'm not going to go into that. It's an erudite audience. I'm sure you all know that. So there's obviously a supracondylar fracture with, oh shit, my alarm's going off. It looks like I've reminded myself to do something, but I can't remember what. Maybe it was talk on this. Anyway.
Yeah, give a talk on OrthoHub's webinar.
Possibly. So yeah, so in this case, so this is one of the difficulties with Bowman's angle. So if you're talking about the original Bowman's angle, this is Bowman's angle increasing, showing cubitus valgus. But if you talk about some of the other things, this is actually Bowman's angle decreasing, showing cubitus valgus. So just be a little bit careful in how you describe it. And there's obviously an anterior humeral line just sort of clipping the front of the capitellum. All right, so then just talk a little bit about rotation, because some trainees get a little bit worked up about this, and it's not too difficult. So remember, in terms of the shape of the humerus, it's like two cuboids. And as you rotate one relative to the other on an AP view, one will look wider than the other, and that's as simple as it is. And if it's noticeable on an X-ray, then it's probably too much to accept. And there's an example of one. So it's a lateral X-ray, so you've got a much wider bit proximal and a much narrower bit distal, and that can really only be explained by rotation. So if it's big enough to see in an X-ray, it's probably too much to accept. So next bit is about who needs an operation, and I don't think there's not too much in terms of controversy here. So all displaced fractures, so Gartland 3, I don't think there's many people that would treat a Gartland 3 conservatively. If there's any coronal or axial plane angulation, you could say low threshold, maybe no threshold. So if you have got cubitus varus, cubitus valgus, or visible rotation on an X-ray, then you should probably intervene. And this is generally fairly well accepted that if your anterior humeral line doesn't intersect the capitellum, you should probably intervene. I've got some concerns about that one in the sagittal plane, but it's generally fairly well accepted. Next thing is timing. This is much easier than it looks. So this is an evidence-based guideline that we produced a few years back. So we'll just go through each little bit of it. So first thing, as a radial pulse palpable, yes. Is there a neurological deficit? No. And that is going to be the vast majority of the supracondylars you see. And those ones, they can wait to the next day's list. There is no evidence that intervening early affects your ability to reduce it, or your quality of reduction or patient outcomes. We always like to think it does. A lot of paediopods say that, yeah, we need to get in there early because it's easier to reduce. And actually, to be fair, that's what I tell my adult surgical colleagues mainly, so I can get in first on the trauma list the next day. Oh shit, I've just thought there's probably people from Coventry in the audience. I didn't say that, no, absolutely not. If there is a neurological deficit, again, most people would just say that this needs to be done urgently. So I don't think there's many controversies there. So let's go down the other side of it. So radial pulse not palpable, but if you've got a perfused hand, so the so-called pink pulseless hand. So this one, there are some sort of slight controversies here. So I think everyone would agree you need to do this fairly quickly. You don't want to leave these a long period of time, even though they're perfused, so the hand's not in immediate danger. I would call this urgent surgery rather than emergent surgery. So I wouldn't rush them to theatre, 2 a.m., but I would do it as soon as I could. Then you've got to make a judgment intraoperatively about whether or not there's a block to reduction, and preoperatively about whether or not there's a nerve palsy. Okay, so let's do the second bit first. So you've got a pink pulseless hand and a nerve palsy. So this is Mangat's paper. This is Ed Beisch. Oh man, 2009. Jesus, I still think that's a new paper. Anyway, so if there is no block to reduction and there is no nerve palsy, preoperative nerve palsy, then wire and observe. So the difference here, there's no difference in your wiring technique, that's the same, but these ones I don't send home straight away. I observe them for 24 hours. They've got a higher risk of compartment syndrome. So this is a pink pulseless hand, no block to reduction, so you get perfect reduction, no pre-op nerve injury, wire them as you would normally, but don't send them home 4 hours later, keep them for 24 hours. Then this is the bit that not everybody agrees with, and I got not entirely sure I agree with either, but anyway, so if you do your urgent reduction and you either can't reduce it perfectly, so something's in the way, or you've got a preoperative nerve palsy, then you should consider exploring the antecubital fossa, because sometimes the neurovascular bundle is entrapped within the fracture. So have I done this often? I have done it, but have I done it often? No. And I usually judge it a little bit on this bit here. So if I've got a perfect or near perfect reduction, then to my mind, even if there is a pre-op nerve palsy, there can't be anything in the fracture if I've reduced it spot on, or got end-to-end apposition and so forth. If I'm really struggling to reduce it, or it's clear that I'm not getting a good reduction, then I might be tempted to open it anyway, although the number of those I actually do is pretty minimal. But this is what this paper suggests. So this is a slightly sort of controversial area. And then this one again is less controversial. So this is now you've got a white pulseless hand. So this is a hand that's just about to die. So these obviously need emergency close reduction. They don't wait a minute longer than they have to. You need to inform your vascular team. You do not need an angiogram. If you do your reduction and the pulse returns, then a bit like when you've got a pulseless pink hand, you wire them as you would normally and you observe them for 24 hours. Again, don't send them home 4 hours later. Higher risk of compartment syndrome and other complications. If, however, your pulse does not return, so you've done your reduction, you have no pulse, and you've still got a white hand, then this is where you need your vascular surgeons to help you. And usually the vast majority of arterial injuries associated with supracondylar fractures are because the artery is just tented around the front of the fracture site, and once you've gone in and they've dissected out the artery and freed it from the fracture site, then the pulse returns and everyone's happy. Every now and again there's an intimal tear, or so you do need for those of you who read the BOST guidelines, you do need a surgeon who's capable of doing a small vessel repair. So that's when you need your vascular surgeon to take over and fix the artery. But I know I've seen this I've been a consultant now 10 years, fellowship. I've seen this one case in my entire career of a white pulseless hand that didn't get better, and that was as a fellow in the sick kids, where they get dozens and dozens of supracondyles. Okay, so we'll just go on from that, and that's just the whole guideline put together. All right, so that's when to operate. So now I'm just going to talk a little bit about how to actually do it. So whether you use lateral wires or you choose to use cross wires, it doesn't really matter. You just got to make sure you get bicolumnar fixation, and you need a good spread at the fracture site. Feel free to put your K-wires through the capitellum. You do get a lot of trainees, even consultants, who seem obsessed with trying to miss the physis or miss the capitellum or avoid it. It's not necessary. I don't want you to turn it into a pepper pot. So, going in, out, in, out, in, out, in, out repeatedly with your K-wire is not a good idea. But try and you can go straight through the ossific nucleus of the capitellum. You can go straight through the capitellar physis with a smooth device. So this is something you often see. You see people desperately trying to avoid the physis. Also, the physis is still here. It's, the cartilage is all around here. So you've avoided the ossific nucleus, but you've still gone through the physis. But you do see that from time to time. So I'd much prefer you to do this kind of thing. So you've got bicolumnar fixation. You've got a good spread, kind of a third, if you like, and you've got good fixation. I mean, obviously, if this fracture is a bit higher, this wire might need to change and so forth. But yeah, you can ignore. You don't feel afraid of going through the capitellar ossific nucleus. As I said, go in. So what I tend to do if I'm doing it with a trainee, I'll get this line this up on the AP, get the wire into about here or so, then get a lateral to make sure you're not going too far forwards or backwards. So ideally a single pass, so you're not going in, out, in, out, in, out, shake it all about. If you do want to do crossed wires, again, you can screw this up as well. So if you do crossed wires where you're crossing right at the fracture site, you got very little rotational stability. So again, you want to try and get a decent spread at the fracture site by columnar fixation. Actually, that red line could probably do with going that way a little bit. And this is hot off the press. So this came out in the Journal of Journal of Shoulder and Elbow Surgery, meta-analysis of RCTs, and there is evidence of very low quality that fixation with lateral wires is slightly safer regarding nerve injury, and cross wires is more effective in terms of stability and maintaining reduction. So you can choose whichever technique you want. If you do it medially, make sure you don't stick it through a nerve. And then this last bit's really important is, and I'll show you how I set these kids up on the table. So there are some supracondylars, and I'll show you an example of one in a minute, are really, really unstable. And they're the ones that when you're getting your lateral, most of you, as I'm sure you do, will move the arm to get the lateral rather than the image intensifier. And if you get one, so I'll say, just got it lined up on the AP, then you get the lateral and it looks like shit. And then you put it back to the AP and you get it lined up, and then you put it back to the lateral and it looks like shit. That's probably just because it's so unstable. The posterior periosteal hinge is not intact. You're not getting that tension band effect of flexing up the elbow. And so in those cases, it works better if you move the II machine. But to do so, you need to set them up right. So this is a lad, he had an open supracondylar, so that's why he's got a little wound there. So you get you line them up on the table like this. You get ideally an arm board without legs, because it makes it much easier. You have the head here, so that as you're pulling, if you were pulling, the head goes onto your arm board, not into this hole down here with the arm support here and here. You get your II coming in parallel with the body up to here to get here. And the reason I have it that way, because I tend to use lateral wires. That means I can sit here and I can put my lateral wires in that way. And then if you want to get a lateral, oh, sorry, that's just where the head position, not there, head position there. If you want to get a lateral, you can then swing the machine around for your lateral. So for those really unstable ones, particularly the ones that are unstable in flexion and extension, you can now move your machine for your lateral rather than moving your arm for a lateral. It just is a little bit of a get out of jail card sometimes. You don't need to do that every time if you've got a stable reduction. But if you set it up right in the first place, it gives you that option. Next thing, this is my son, who was a willing model last night. This is kind of the way most people are taught how to reduce supracondylars. You put my right hand up here holding his arm, you can put a little bit of traction on, you can control the flexion extension. My left hand, fingers over the front of the humerus, my thumb behind the olecranon. Any of you have ever had an ulnar collateral ligament injury, as I have, this hurts. This puts a lot of force through that thumb, and you can't really control rotation desperately well. You can a little bit up here. So it is a way of reducing it. And actually, to be fair, I tend to do that as a first line, but this often works better. It's a lovely technique, this. And I was so glad when someone showed me how to do it properly. So you do need an assistant to hold the arm. You get your fingers around the front. Now you've got two hands pushing, not just one. You've got both fingers around the front. One thumb kind of on his medial epicondyle, one thumb on the lateral epicondyle there, and you can milk it round. You can start off with a bit of extension. You can flex it up. You can push a bit more medially or a bit more laterally if you've got a fracture that's displaced in one of those two directions. It gives you a lot of control, much more force. It's much more comfortable, and I use that technique a lot now. So it's just a much sort of more powerful way of reducing your supracondylar fractures. And initially, if it's really displaced, you can kind of get your thumbs almost right, dig them right in there and push it distally and milk it round until you get it into a good position. It's a lovely little technique to use. So this was that lad I showed you with the open supracondylar, so it was poking out that way. Fortunately, missed his nerve. So I don't think anyone would argue that this needs fixation. So we took him to theatre and we put him back. And this is what it looked like after the guys in A&E had reduced it, because it was sticking out the bone. They reduced it like this. And these are the ones that ring alarm bells. So once this has been reduced, it's gone into flexion. So it started off out here, and then they've reduced it and it's gone into flexion. So clearly that posterior periosteal hinge is torn to buggery. There's very little primary stability, and these ones are a bugger to get right. And this is where we got it. And I'm sure out of the 350 of you, there's some people swooning and gasping and acknowledging my undoubted godly skills, but you're never as good until you take your lateral. And it's definitely not that good on the lateral. But by that time, there was a lot of swearing and I was fed up, so I accepted that. And actually, as I'll show you in a minute, I'm not overly fussed. It doesn't project very well, but actually I think it's translated, not rotated. So the back of this bit is coming up here. So I think overall the width is okay. So I don't think it's too rotated, but it's definitely translated. And the anterior humeral line is miles in front of the capitellum. So I'd like to just keep that picture and just ditch that one. But anyway, But the reason why I don't sweat too much about the sagittal plane deformities is partly because I trained in Stoke, where historically they used to treat all of these supracondylars on straight arm traction, even these displaced ones. These are the pictures from John Dwyer's paper back in 2005. Yeah, 2005. Geez. And if you watch these for a bit of time, these are treated on traction, straight arm traction. They remodel brilliantly, and their long-term results were superb. So the traction controls the varus valgus, it controls the rotation, and the sagittal plane works itself out. So having trained there and seen all these fractures and seen them in fracture clinic, I'm a little bit more relaxed now about sagittal plane deformity. So going back to this one, I think that's going to remodel it, but you know, I might be wrong. And then more recently, James Gamble's paper in 2020 looked at remodeling, and actually the under 8s remodeled incredibly well, and they can remodel 100% displaced fractures like this one. So there's certainly a bit like everything in kids. There's a bit of an age-dependent thing. The younger you are, the more remodeling capacity you've got. You know, as this kid grows, this lump here is going to be further away from the joint and so forth. So yeah, so certainly I think you can get away with a lot in younger kids that you can't in older ones. So down and then down here, so let's say the last point, don't worry too much about sagittal misalignment in my practice. So then the last one, so this paper was titled The Success of Closure Reduction. I'm more of a glass half empty guy, so this is Predictors of Failure. So these are the predictors of failure, and there's 2 of these that you can control. You can't control how oblique your fracture line is, but you can make sure you've got good wire spread, and you can make sure you've got bicolumnar fixation. It's often, you know, certainly common when I'm doing it, even when registrars are doing it, the first wire goes right up the middle, but it's a really good hold. You're holding properly, holding distally, but it's right in the center on the bone. So then just use 3. Then you've got bicolumnar fixation. You've got decent spread. You don't need to take out the first wire if it's in the bone. Follow up. I follow up all my supercondos, even the undisplaced ones, with 1 week for an X-ray, and then if I've operated on 4 weeks for a cast off and wires out, I don't do any further X-rays or follow up unless there's a reason to. And then a bit, let's say Pranay alluded to, we're doing a lot of hard soft combo. So if they're conservative match, the grade 1s that you haven't taken to theatre, we do a hard back slab and then soft cast over the top. And Viscos have produced some videos of showing patients how to unwrap and take off casts, and you don't need any further follow up in those cases. So the BOST guidelines, as most of you will know, say you should get an X-ray between, I think, 4 and 10 days. I think it says on the guideline, and I do that. But then, if they're conservatively managed, sometimes you get a bit of a gut feel of whether the parents are up for it. They'll take their cast off, and I don't follow them up again. And rather depressingly, this paper came out in 2020 and said it didn't make a difference whether you were a paedipod or a general orthopaedic surgeon. So none of you buggers are getting out of fixing supracondylar fractures or referring them to a paedipod, because you can do them just as well as we can. Okay, thank you very much.
Man, that was awesome. Thank you very much, Steve. Sorry, I didn't realize some people are putting questions on the chat rather than just the Q&A. Right, so we've got some here. Thanks, Dr. Cooke. This is from yeah, this is from Dr. Anonymous Attendee. They've asked quite a few questions today. Thanks, Dr. Cooke. When performing an open reduction of a supracondylar fracture, what approach do you use most often?
Yeah, so I very, very rarely do open reductions anymore. Hardly ever. And the ones I've done are the ones where I've been interested in what the nerve or the vessel is. So I've gone through the front. And then every now and again, so this lad had a puncture wound medially. It was fortunately just in front, so we just extended that, and that was kind of a medial approach. I don't think it matters a great deal, but it depends a little bit on what you're interested in. So, like I said, I've done very, very few open reductions, and the ones I have, I've been worried about the nerve or the vessel, so I've gone through the front.
Yeah, Pranay, Claire, would you agree with that?
Yeah, all approaches to distal humerus are described within the literature. The posterior one is probably the no-go area due to the vascularity of the distal humerus, but actually it's all described. So it's a bespoke, again, utility approach depending on the fracture configuration. Yeah.
Someone's asked whether you've used finger traps for reducing the extension type supracondylar fractures.
I haven't. No, I've never felt I needed to. Usually, just pulling is enough. I've never tried finger traps.
Right. No one? No. I don't. And then, do you routinely remove wires in clinic or patients require theatres? I would say clinic is the gold standard now. And in fact, having said, James Hunter is doing the girth visits, and I think he's actively discouraging trips to theatre just to remove K-wires. I mean, it really isn't necessary. I think the kid cries just as much having a Venflon stuck in for their anaesthetic or when they're having their anaesthetic as if you take the wires out. They don't normally cry. Right, Bijay Thomas, if encountered with a completely displaced, neurovascularly intact type 3 fracture out of hours, brackets, say around 8 p.m, close brackets, would it be reasonable to fix it overnight? Is there a chance of delayed neurovascular compromise due to progressive edema or brachial artery contusion /spasm?
So sorry, it's just like, as you said, neurovascularly intact?
Yes.
So there is no evidence that doing it overnight makes any difference?
Yeah.
So I would wait till the next day if they are neurovascularly intact.
Even at 8 p.m?
Yeah. I mean, if there's, if there's a reason to, like skin tenting or
Yeah.
I mean, the other thing is what you mean by neurovascularly intact. Examining a kid with a really displaced supracondylar, I challenge anyone to exclude every single nerve injury. So I'd much prefer trainees and consultants to say they couldn't examine a particular nerve rather than just say NV tick. And if you can't definitively exclude a neurovascular injury, then you should assume it's injured until proven otherwise. And
I mean, this is a paediatric orthopaedic session, so you've got to mention Dan Perry a few times, and then they showed that, didn't they? Their unit, Orderhay, and another unit have shown that actually these things are just poorly documented. So that's, the Bose guideline does specify the 3 nerves, motor, sensory. I think it's not just, it's a type 3 fracture and there's no neurovascular compromise. It's the other things. How swollen is that elbow? Have you got massive bruising in that antecubital fossa? And if it is 8 p.m, I have to be honest, I would rather do it in the first few hours after that than waiting, and unless you're going to get it done first thing in the morning. But I think you're right. There's no evidence that this makes a difference. Although that year in the BJJ, I think it was Glasgow said there's no difference. Edinburgh said there was a difference. And I think everyone's got their own ideas about these things. What about you, Pranay, Claire? Do you feel strongly one way or another?
10 o'clock, my cut off.
Yeah, I think
in the car turns into a pumpkin.
Yeah.
Yeah, I think about the same. And also it's mainly, it's the toddlers, the younger ones with the really chubby arms. They just become more difficult to do the next morning. So sometimes it's nice to do them, but yeah, you have to have a firm cutoff. And I think you need to be in charge of that cutoff.
Yeah.
So certainly in my hospital, if someone comes in at 8 p.m, they ain't getting to theatre before midnight.
Here it says wire size, age related, yes, 2 millimeters.
Yeah, so the Bose guidelines say 2 millimeters for everybody. For the really young ones, I sometimes use 1.6. I tend to err towards 2 millimeters, but yeah, sometimes 2 millimeter wire in a 3-year-old's elbow sometimes looks massive.
But it's so nice. It's so stable and big.
They are to
they
the
go
power
in much easier.
They do. And there is a paper where they've described how you can measure the thickness of the cortex and plan your wire accordingly. But really, if you're fixing a lateral condyle fracture in a 3-year-old, you wouldn't be going, that 3.5 millimeter screw is a bit too big.
Yeah.
So I think you can get a 2 millimeter wire in there. Karen Chu has asked, can you please explain the optimal wire configuration to achieve best bicolumnar fixation? I thought your drawings, your pictures, Steve, did that really nicely, but it is essentially looking at one wire. If you're going for your lateral wires, I'd say one going straight up that lateral column and one crossing. And don't be afraid, you mentioned going through the capitellum, but also I think crossing the olecranon fossa is a really good thing because you're getting cortex and another cortex. So you're going to be in a plaster 3 weeks. So those are the things I'd say.
Yeah, I think it's really satisfying getting that kind of 4 cortex feel when you get your wire, and it makes you feel like that's solid, that ain't going anywhere.
Yeah, we're a sad bunch of people, aren't Wahib Al-Azani has said, how would lateral divergent wires result in nerve injury? Mate, we with wires can injure anything.
It's amazing how many wires go wildly out the front. It's incredible. So a lot of people, I think, especially when they're learning, seem to start too posterior and aim anterior. And you take your lateral X-ray and you've got a wire pointing miles out the front. I suppose one of the slight problems with the 4 cortex feel with your olecranon fossa is if you kid yourself you're in the olecranon fossa, but you're actually not. You come out the front and you carry on going and say, oh shit, I'm not feeling another cortex. And then you take your lateral X-ray and you're wildly anterior.
Right, and then we've got Thomas Key, may I ask, as per the BOSE guidance, in your opinion, what constitutes adequate techniques to avoid ulnar nerve injury of use of medial KY? I think that's really controversial. So some units say you've got to have a big enough incision to visualize the ulnar nerve. A lot of people thumb in, sweep soft tissues back, so you're on the medial epicondyle. Others say you can do it with the elbow, with a percutaneous technique, but the elbow's got to be extended.
Yeah.
I think the key is documenting what you did.
It's the ones that the common supracondylars, the extension types, are stable in deep flexion, and there's a bunch of kids that the ulnar nerve sublux is anterior at that point, and it's either right in front of the medial epicondyle or over it. So your wire either goes behind it and then it tenses massively, or you go through it. So that, I think that's the issue. So if you, I mean, I very rarely put a medial wire in, and if I do, I usually do a little 1 centimeter incision, put a clip right down onto the bone. If I'm on the bone, I can squiggle it back and forward, and I'm convinced there's not a nerve there. Then, and to my knowledge, I've not permanently damaged someone's nerve, but I've certainly had a kid wake up with an ulnar nerve palsy and then taken out their medial wire before.
So the other thing that I teach my trainees to do, because when you put your wire into the wire driver, you've got a big long lever arm and you've got a heavy weight on the end of it. I get them to take the wire into their hand and place it up against the bone and have that tactile feedback of the wire being placed either on the cartilage or the bone. And then they can tap that in with a little toffee hammer. And then they can use that to direct, they get their entry point and then they can direct the wire. So that sometimes is useful to get that tactile feedback as you're going in onto the bone.
Yeah, one of the things that James Fernandez teaches, which I think is really useful, is oscillating the wire when you start. So that way you're less likely to wrap neural structures or anything. So I'm a big believer in that. Peter Craig, any role for traction of supracondylar? I think that's making a bit of a comeback, isn't it? You know, in the AO course, Fergal Monsell talks about that. I have to be honest, when I did the BISCOS survey, and it's been quite a while ago, I thought, man, who's this kind of wimp who does traction for supracondylar fractures? And then you see John Dwyer's pictures of pelvic fracture fixations in 8-year-olds. You think, man, this guy's not a wimp. But apparently the results are really good. And as you said, you know, the guys who trained there, and even here at Norwich, my predecessor used traction a couple of times. And you see these x-rays that look like they're not great at the beginning, and then you follow them up over months and they actually have a really good outcome. And I think that's one of the big things. And Uni Narayan has shown this. You can accept a lot of deformity. And I think the big thing in that sagittal plane is just having your anterior humeral line crossing that capitellum. And Steve, that paper that you quoted, they kind of showed that, didn't they? Sometimes you might forward flex that distal fragment, but not translate it. But as long as that capitellum is being crossed by the anterior humeral line, you're okay. Right, someone has asked what to do if perfect reduction and 1 week follow-up found displaced. That's one of the cases that we discuss in the case report, so tune in next week. Rami Kajali has said, thanks for the great talk. Do you do traction for 5 minutes routinely?
5 minutes is too long for me. I get bored. I do try and do a minute or two. I mean, it depends on the fracture to a certain extent. Some of them you might end up doing 5 minutes by the time you've added it all together. But yeah, it wouldn't be a routine thing. 5 minutes is a hell of a long time to pull on a kid's arm.
So James Hunter was talking about the guitar bit in Stairway to Heaven, wasn't it? I'm not sure how long that is.
3.5 minutes, apparently.
Is that right? So normally I say that while we're pulling, and by the time I've said that, it's kind of like, okay, let's move on. But it really does make a difference. It's just try and resist the urge to do a quick pull and then say, right, now we're going to get on with it. Just some gentle, proper traction. Someone had asked, Dinesh Bhaskaran had asked whether you reduce the fracture before you scrub and prep and drape. I have to be honest, I used to do that as a registrar when I thought, is this going to be straightforward or do I need to call the boss? And these days you just realize that actually if you reduce it, unless you're going to tape it like this, which I don't think works, you might as well just scrub up, prep and drape, and then just get on and reduce it.
I wire them all, so yeah, I don't see the point in doing it that way. Just scrubbing everything.
Do any of you take a kid to theatre and just do a closed reduction without wires? Yeah, I personally, so for me, those are the ones that are getting the lateral wires for sure. Okay, so if it's a Gartland type 2 or an AO type 2, 3, that's where I tend to favor my lateral wires. Kebab Osman, would you recommend using 45-degree oblique views to assess reduction medial lateral columns? Yeah, that whole Jones thing, I think that works really well. And I think we've answered all of that. There's a lot of, do you always use 2mm wires? It does depend on the age of the child and the size of the child. And someone's put here, how do you take out wire in the clinic when the child won't even let you touch her arm? I think it's lots of distraction and giving them no choice. I think once a year we do have to end up taking, I've had one person who wouldn't actually let anyone near her arm. And even when we tried to mark her to take the wires out for theatres, she threw the marker pen at her dad. I would give the marker pen to dad and say, can you mark the arm? And she just chucked it at him. We don't try with those ones. So you can work that out in advance. Guys, has anyone used an X-Fix for difficult displaced fractures? Because that's a well-recognized technique.
Also, you can always touch their arm. I mean, there's no such thing as a kid who won't let you touch their arm. You're going to take the cast off. We kind of don't make a big thing of it. So we get the pliers ready as the cast is coming off, take the cast off, whip the wires out, job done.
Yeah. Yeah, anyone used an X-Fix?
I learned it on the PDAO course, never used it.
I would really like to. I think it's a great idea. Post-wiring, do you screen the range of movement and stability to give you confidence at straightening the elbow on the ward? That is one of the things, but I'd say the most important thing is the whole screening from internal to external rotation. Okay, so a lot of these fractures are always stable in internal rotation. That's why cross-K wiring is so good for those ones, because you're facing that medial side. But then you want to screen it into external rotation, because that's how they have their x-rays taken. When they come back the next week, the arm is like this. And so basically, if you haven't checked that it was stable in that position, that's when you find out it wasn't. Jen Barwell, hey Jen. I just wanted to ask if at a DGH setting without vascular and there's a pink and pulseless supracondylar, would you prefer general orthopod to take to theatre or to discuss with larger centre for potential transfer? What do you guys say?
So pink and pulseless, you don't need a vascular surgeon. So white and pulseless, you do need a vascular surgeon. But I mean, John Dwyer made this point as well. If you've got a white hand in front of you that's been white for 3 hours, 99.9 times out of 100, it's not an arterial transection. It's just the artery is kinked over the front of the fracture. And you can cure that by just reducing it.
Does everyone agree?
Yeah, agree.
We've had a couple transferred to us when they tried that, even for the pink and pulseless, and then had concerns about loss of color. Yeah, they've called. So it's happened to my colleague, Helen Chase, a couple of times. She's then transferred the patient over blue lighted and gone straight to theatre to deal with it. So there's no harm in trying as long as you have a bailout plan in mind. Do you maintain the elbow in pronation or supination? And yes, it does depend, as you said, on fracture pattern and rotation. But sometimes there is that whole thing about, normally it's posterior medial and you've got to pronate. Actually, sometimes when that's not working, just supinate and you find it works. Just try everything.
Nonsense. I found no relation. I try it one way. If it doesn't work, I try it the other way.
Yeah. And actually, Steve, I've got a bone to pick with you. How dare you tell these people that they've got to rotate the II? That was my little trick. That's the thing that separates me from everyone else.
I didn't say they had to rotate the eye. I just have it as an option, because it's
it does really work. When they're that unstable, actually spinning the II around makes all the difference.
So I hardly ever need to spin the II, but it's useful to have that option.
And I think that paper that you refer to was written by a paediatric orthopods. They could tell the general orthopods just to get on and do it. So they said, how are we going to keep quiet overnight? Let's tell them there's no difference. Okay, Dr. Anonymous attendee again, Steve. Great talk. What are management options in iatrogenic ulnar nerve injury? More interestingly, is that a Peloton bike in the background? What is your experience of that? Cheers.
I'll answer the second one, but no, it's a Watt bike. Yeah, Watt bike. I have to admit, I very rarely use it. It's mainly my wife and daughter that use it, but I do need to. I've turned into a bit of a lazy bastard during lockdown. I used to be fairly active, but lockdown to me seems to be an excuse to do as little as humanly possible. What was the other question? I've kind of forgotten.
Yeah, management options in iatrogenic ulnar nerve injury. So I think you've already said it.
So I'd take the medial wire out straight away. I might extend the elbow a little bit, and then I've never seen a permanent one. And there was a review recently, wasn't it, of nerve injuries, not just iatrogenic ones, but nerve injuries around supracondylars. I can't remember who wrote it, but they found almost no one had a permanent injury, even if you put the wire straight through the nerve. So I think, yeah, just take the medial wire out.
But we're not advocating that.
No, we're not advocating that. We don't try and make iatrogenic nerve injuries. And obviously, if you've taken the medial wire out and now you've only got one wire in, there's an argument about whether you should, probably put another wire back in. I think you might need to judge that a little bit depending on the patient.
Yeah. Medial comminution hasn't been mentioned today, but is often mentioned as an indicator for surgery. Any thoughts, anyone?
I suppose like any comminuted fracture, it makes the the stability of your fracture fixation construct is primarily dictated by the fracture, isn't it? So if you've got a comminuted fracture, you've lost inherent stability, so you're now having to rely more on your wires. So decent wire technique, maybe a third wire, maybe 2 lateral and a medial. Yeah, I mean, the really oblique ones, those ones where certainly more than 30 degrees, we've got 40 odd degrees, and I often then do 2 lateral and a medial wire for those ones, just to give a bit of it, because I know that those oblique ones are a bugger.
Also, I suppose the more difficult decision-making ones are the buckling on the medial cortex, and I suppose the useful thing is to look at the other arm, for because nature gave us something to compare to, and to see if there's any significant deformity, because they're sometimes quite comfortable. And sometimes we will take them to theatre and screen them and treat them if we think there's significant medial collapse.
Brilliant. And I'm just looking through the question. Someone's put, isn't the II getting in the way if it's in the lateral position? No. So you sit at the end of the table. So that arm table that Steve showed you, put the II in front of you and it swings through. Cameron has said, has anyone used 2 II machines? So I did work with a boss, Boyd Goldie from Whips Cross, great guy. He did use 2 II, so one was the mini C-arm and the normal one. I don't have well, we do, but I don't like doing that actually. I'd rather just have the radiologist, the radiographer doing the image intensifier for me. But you're right, it can be very useful. And then if after after reduction and K wiring, we cannot feel the pulse, what should be done? So I would say if it's pink and pulseless, I'm going to leave it alone and watch them for 24 hours and then not care. What do you guys do?
Yeah, I agree, yeah.
I'd probably wire them and not watch them for 24 hours, because in the literature it can take up to 2 weeks for that pulse to come back. I think, again, sometimes Doppler's useful if you want to make yourself feel better intraoperatively. But yeah. So
I'm not keeping them for 24 hours for the pulse so much, but it is one of the risk factors for compartment syndrome. I know compartment syndrome, what's only 0.5%, isn't it, or less than that, something for supercondylar, but it's one of the risk factors is a pink pulseless hand. So Claire, I don't think the pulse is going to come back in 24 hours, but I just want to make maybe 24 hours is a bit excessive, but I wouldn't send them home after 4 hours, maybe a bit longer.
Right, guys, I'm going to finish. The questions are just coming in, which is great, guys. You've all been really keen and interested. Thank you so much. We are going to do that Clubhouse session next week, so tune in then. And yeah, we didn't go through those case discussions. There will be a little video to explain things, but I think those would be really interesting to discuss as a group next week, because we've had a bit of a discussion already, and there are some controversies, and that was the whole point of those cases. So I'm just going to finish with a bit of a summary slide, if that's okay. So I'm just going to share screen. So in summary, guys, okay, so what am I taking home from this? Okay, these are the things you are going to do. NAI, I quite liked Claire calling it maltreatment, because that's what it is. And let's not pretend it's anything other than that, okay? You are going to actively exclude maltreatment in any child that you see who's under 2 with a fracture. And even beyond that age, as we discussed with the adolescents, there are things to think about. So please do look at the whole person and family. And she's given you that mnemonic, okay, ARCs, and use ARCs so that you don't look like an arse and miss things. Femoral fracture, I think Pranay has nicely shown us that age is going to guide treatment. You've got the walking spiker of Budev, and there seems to be a lot of interest in that one. I personally feel that elastic nails are the workhorse in the 4 to 9-year-olds-ish, and that the lateral entry nails and submuscular plates are shifting those goalposts. If the person in the bed looks like they're about the same size as you, I personally wouldn't be using elastic nails or spikers, okay? And yeah, some of us are pushing lateral entry nails down to 8, but it all depends on the size of the bone. And finally, I think what's nicely been shown by Steve is that lateral or cross KYs, there's this whole controversy, oh, am I East Coast, am I West Coast? It doesn't matter, right? You do it properly, you do a good job, and it's going to work. And one of the things he showed you is planning is key. So the patient, but also the II positioning as well. And don't get too hung up on anatomic reductions, but it's about knowing what deformity you can accept. Okay. So as I said, the cases, we will have a little video available soon, and we will discuss in the Clubhouse next week. So please do join us for that. I wanted to thank Author Hub Cash Akhtar, Mike Barrett has done a lot of work behind the scenes for letting us do the session. And I've got to say a big thanks to these 3 speakers. I've learned loads. They've been great, and I hope you found that. And of course, I've got to thank you for joining in and staying with us. It was a really good turnout, and I'm really chuffed. Thank you very much. And Mike, do we finish there?
Yeah, thank you very much, everyone, for attending tonight and for joining the session, and to our speakers as well. And good night.
Brilliant.
Everybody, night night.
Good night.